Roughly 11% of children in the United States are diagnosed with ADHD. That's a massive segment of the student population in classrooms every day. When educators and clinicians hear the acronym, they automatically picture a specific profile, the physically disruptive student who simply cannot stay in their seat. That bias obscures the reality of pediatric ADHD inattentive type. This is a quiet, highly masked neurodevelopmental condition. It is driven by executive dysfunction, a biological failure of the brain's management system, not a lack of motivation. Because these students aren't interrupting class, they are routinely mislabeled. Teachers often describe them as spacey, lazy, or underachieving, completely missing the underlying neurological deficit entirely. When we rely on visible disruption as the primary trigger for an ADHD screening, an entire class of vulnerable, compliant students is left completely unidentified. This clinical invisibility is known as phenotypic masking. It occurs when severe internal executive deficits are successfully hidden behind a wall of outward behavioral compliance or high baseline intelligence. For academically gifted students, this masking requires immense personal effort. They use their raw intellectual ability to brute force their way through neurodevelopmental gaps, exhausting themselves to compensate for a lack of working memory or sustained focus. This strategy inevitably leads to severe academic burnout. These students are effectively working twice as hard as their neurotypical peers, just to yield half the expected academic result. Leaving this masked deficit untreated carries severe long-term risks. The constant strain of overcompensating frequently triggers secondary anxiety, clinical depression, and a significantly elevated risk of substance use during adolescence. In clinical assessment, we have to recognize that the absence of action, the inability to initiate and sustain attention, poses the exact same danger to a child's development as hyperactive disruption. When we look at early childhood educational screening data, a clear systemic diagnostic gap emerges. Specific cohorts of students are being chronically overlooked. This chart highlights the stark gender disparity in current ADHD diagnoses. While boys establish the baseline, the diagnostic rate for girls drops 2 to 3 times lower. But the underlying neurological prevalence of ADHD is actually similar across genders. This massive empty gap between the diagnosis rate and the actual neurological rate represents a systemic failure to identify inattentive girls. The exact same documented underidentification occurs within Black and Latino student populations, with their diagnostic rates falling well below the expected statistical baselines. Connecting the baseline across these lower demographics allows us to clearly map out an underidentification zone, a massive blind spot in our educational health system. This demographic gap is compounded by systemic biases in classroom observation. Educators are trained to flag disruption, inadvertently ignoring the quiet students whose minds are constantly drifting. The data proves that our traditional approach to screening is largely reactive to physical disruption, rather than proactively assessing a child's executive function. To correct this, clinicians rely on the strict thresholds established by the DSM-5, which strip away subjective biases and prevent casual misdiagnosis. This structural matrix maps out those rules. The baseline requires a child under 17 to display 6 or more specific inattentive symptoms, with the initial onset occurring before age 12. Next is the timeline constraint. These symptoms cannot be a brief reaction to a life event. They must persist continuously for at least 6 months. Finally, the environmental constraint demands that these symptoms negatively impact functioning in 2 or more distinct settings, such as failing to perform at both home and school. In the classroom, the clinical criterion of failing to give close attention to detail rarely looks like outright defiance. It looks like extremely slow processing speeds on multi-step instructions and the constant misplacement of basic materials. Another major symptom is the inability to initiate or sustain effort on repetitive work. A student might perform brilliantly on highly engaging, novel tasks, but completely stall out when faced with routine homework. When these children fail to follow through on instructions, it is a mechanical failure of working memory. It is explicitly not driven by oppositional behavior or an inability to grasp the underlying academic concepts. A true diagnosis requires observing this persistent, cross-environmental breakdown of executive function, ruling out temporary situational stress entirely. Identifying that breakdown requires a careful differential diagnosis, because pure attention failure is a surface presentation shared by multiple mental health conditions. Looking at this diagram, you can see how ADHD and generalized anxiety overlap. While ADHD is driven by executive dysfunction and anxiety is driven by worry, they both produce the exact same external result, attention failure. With anxiety, the brain is forced to abandon focus because intrusive worry hijacks the child's cognitive load. From the teacher's desk, an anxious child zoning out looks identical to a child with an executive deficit. We must also expand this evaluation to include depression, where attention is disrupted by low mood, as well as specific learning and language disorders that cause a student to check out during class. Simply observing the symptom of inattention is not enough. Isolating the exact neurological driver behind that symptom through a comprehensive evaluation is the only way to apply the correct treatment. Once that diagnosis is confirmed, clinicians deploy the multimodal architecture. Established by the MTA study, this is the gold standard evidence-based treatment framework for moderate to severe ADHD. This framework is built on 4 pillars. The first and often primary intervention is pharmacological treatment. Clinical data shows a massive 70 to 80% positive response rate to FDA-approved stimulants like methylphenidate and amphetamine-based medications for children age 6 and older. When primary stimulants are unsuitable or ineffective, prescribers turn to well-studied non-stimulant alternatives like atomoxetine or gateway medications. The second pillar is behavioral parent training. For younger cohorts between the ages of 4 and 8, this stands as the single strongest evidence-based intervention available. The third pillar introduces cognitive behavioral therapy, which is specifically targeted at older children and teenagers to help them consciously build organizational and time management skills. The final pillar consists of formal school supports. This includes 504 plans and IEPs that legally mandate classroom accommodations like preferential seating and extended testing time. The MTA study definitively proves that this coordinated, combined approach of medication and structural behavioral support vastly outperforms any isolated single-method tactic. Accessing that multimodal treatment requires formal validation. There are strict legal and clinical boundaries regarding who is actually qualified to render an official ADHD diagnosis. This diagnosis must exclusively originate from licensed clinicians. That means pediatric psychologists, child psychiatrists, pediatricians, or qualified licensed clinical social workers. These professionals rely on standardized psychometric tools, specifically Vanderbilt rating scales collected from both parents and teachers, alongside highly structured clinical interviews. Relying on informal assessments is entirely invalid. A social media quiz, a parent's internet search, or a casual hunch from a well-meaning teacher does not constitute a medical diagnosis. Rigorous, legally compliant clinical validation provides the necessary medical evidence required to implement specialized classroom and pharmacological supports. Executing this complex treatment plan requires a highly coordinated care network, one that actively bridges the gap between medical prescribers and the daily classroom environment. Dedicated school-based programs exist to operationalize this integration. For example, MentalSpace School provides Georgia districts with direct teletherapy and precise care coordination to manage these exact requirements. This animation illustrates the ideal intervention ecosystem. By connecting the central student directly to a clinician, their parents, and school support staff, we form a closed, supportive loop. When schools implement these integrated care models, connecting teletherapy directly to classroom behavior plans, data shows an 89% improvement in student attendance. Furthermore, by providing predictable school supports, these programs have documented a 92% reduction in co-occurring anxiety. The data points to a clear urgency for earlier intervention. Identifying these quiet, struggling students early allows for the implementation of 504 plans before a cycle of academic failure becomes established. Correctly identifying and treating the inattentive subtype replaces an invisible struggle with a documented, manageable plan.